Hello, my name is Ehrin Armstrong. I'm an interventional cardiologist at Adventist Health St. Helena. And today I'll be sharing some cases of using intravascular lithotripsy for treating patients with critical limb ischemia. The first case I'd like to share is a 62-year-old man with a prior history of coronary artery bypass graft. He had a recent non-ST elevation MI with a PCI to the LAD anastomosis. The patient had developed a non-healing wound to his great toe, and his ABI was non-compressible, consistent with having significant severe peripheral calcification of his lower extremities, and he had an associated toe pressure of 32 millimeters of mercury. So based on these findings of a non-compressible ABI, the non-healing wound, and the low toe pressure, we proceeded to an angiogram. You can see here in this initial angiogram that the patient had evidence of severe calcification in the distal superficial femoral artery with serial 80% stenoses. And although this is a subtracted image, you can get a good sense that there's severe bulky calcification here in the distal SFA and right near Hunter's Canal. More distally in the tibial region, you can see that there's severe calcification of the anterior tibial and tibioperoneal trunk with 80 to 90% stenoses. And again, this is a subtracted image, but you can see the bulky calcification extending down through this tibioperoneal trunk and into the origin of the anterior tibial and posterior tibial arteries. The runoff in this patient's case was actually primarily via the posterior tibial. This appeared to be the dominant vessel that gave branches to the medial and lateral plantars. And the non-subtracted images, as you can see here, again emphasize that there's no question there's severe calcification. You can see significant calcification on both sides of the artery. It extends for at least around 80 millimeters here in the superficial femoral artery. And you can see this bulk dense calcification in the tibial vessels as well. So based on these findings, intravascular lithotripsy looked like it would have significant benefit for the treatment of each of these lesion types. In the case of the tibioperoneal trunk, you can see here that the lesion was on the range of 40 to 60 millimeters within the tibioperoneal trunk. And in this case, the vessel eyeballed to be somewhere in the range of around a 3 millimeter vessel. So generally, you want to try to oversize the IVL slightly. So we utilized a 3.5 by 40 millimeter intravascular lithotripsy balloon. I inflated this at 4 atmospheres and performed 60 cycles along the tibioperoneal trunk. And you can see here that after those 60 cycles, there was no evidence of dissection, and there was minimal stenosis actually after the intravascular lithotripsy. So this was actually a very good quality standalone result with the intravascular lithotripsy in the tibioperoneal trunk, and I did not use any other further adjunctive therapy in that vessel segment. Subsequently, I redirected the wire into the origin of the anterior tibial, which was also heavily calcified, and then utilized the same balloon, the 3.5 by 40 millimeter balloon, for a total of 100 cycles across the origin of the anterior tibial and the proximal anterior tibial. And you can see here that final result on the right, that there was excellent outflow via the anterior tibial after that intervention. In this case, because I had 100 cycles left after the initial 60, I went ahead and delivered all of those in an overlapping fashion across this approximately 60 to 80 millimeter segment of the anterior tibial. I was completed with the tibial work. You'll recall, though, that the patient also had significant calcification of serial lesions in the distal SFA. In this case, I actually pulled a 6 by 60 millimeter intravascular lithotripsy balloon. Again, in this case, this eyeballed as a 5 to 5.5 millimeter vessel, so I used a slightly oversized IVL balloon. I then delivered 150 cycles at 4 atmospheres, which demonstrated good vessel expansion with minimal dissection. So therefore, I decided to go ahead and use a drug-coated balloon. This was a 6 by 120 millimeter drug-coated balloon that I then inflated at 8 atmospheres for 3 minutes. And you can see over here the final angiographic result. Given that there's significant bulky calcification, you'd expect some mild residual stenosis. This eyeballs as an approximately 10% residual stenosis with no evidence of any dissection, really good distal flow, and no need for any further adjunctive therapies.